The human body is a miraculous organism that adapts to the many stresses placed upon it. Health and well being is dependent upon the integration of nutrition, psychosocial stimulation, pollution stress, medical stress, and musculoskeletal stress. In the case of movement and exercise prescription, the trainer must develop a keen sense of normal soft tissue actions versus the abnormal forces placed upon the body. According to studies, 84% of people with chronic injury exercise with a personal trainer. This presents great opportunities for trainers in the fitness and sports performance industries to bridge the gap with the physio and physical therapy worlds. However, it is up to the trainers and the fitness industry to raise their standards and expertise to gain the confidence and ultimately referrals from the physio and medical world. The body may tell us one thing, but the body will seek the least line of resistance to accomplish a task, often at the expense of the health of the soft tissue and bony structure. In the majority of cases, the body is a liar, as the site of the injury is typically not the problem, but most often is 1 to 2 joint levels above or below that become limited in motion, and a compensation ensues, which is the result at the site of the injury. Therefore, we must perform a functional assessment to understand not what, such as knee pain, nor how will we address the injured area, but mostly the why. What is causing or creating the symptom? When we can address these issues, trainers will create a solution-based, personalized exercise prescription that provides a strategy based upon the principles and concepts of human movement and ultimately greater health and well-being. Functional assessment is a complicated methodology that can be created to fit the needs of the client and the trainer. It does not have to be a series of measurements that is universal to all populations, but should be to the limitations, compensations, and idiosyncrasies of the client's movement pattern. As each person is an individual, functional assessment should compare only the client's abilities to themselves, in other words, you to you, and not to the demographics of their particular age and gender. After an assessment and a program strategy intervention, the assessment should be repeated and compared to the previous results. In other words, functional assessment should compare the client to themselves and measure objective and subjective changes. As my friend and mentor Gary Gray stated, the test should be the exercise and the exercise should be the test. However, this is all based upon the trainer's ability to understand the chain reaction of human movement to create an environment for the client's success. In the numerous gait and motion analysis that I've done over the years, I found certain common limitations that people possess when they come for evaluation. Often many of these lead to some dysfunctions, lead to injuries. And what we have to do is kind of look at these common limitations and identify what they are and clean them up. One of the most common limitations that I see is limited dorsiflexion. We talked about this earlier in movement, but if we cannot get good dorsiflexion through the ankle and we can't get it through the forefoot, you are not going to load the system through the sagittal plane, which will then won't allow you to get adequate rotation in the transverse plane, which then affects the ability to load in the frontal plane. So we need to make sure that we have good dorsiflexion through the metatarsal heads and especially through the ankle and especially through the great toe. So that entire foot complex needs to be loaded. I often see tight hip flexors of the same side and the same side calf get tight. Now one affects the other. If you don't have the ability to go through good dorsiflexion, you're going to limit the ability to go through hip extension. Likewise, if you're tight in the hip flexor and you can't get through good hip extension, you're going to limit the ability to have good ankle dorsiflexion. So one affects the other, and really when you stretch, when we look at the flexibility of highways, we need to make sure that we stretch both the same side calf and the same side hip flexor together, because one can turn off the other. Many times people have come to me and said, I feel tight in the hip. I get them on a table and check the hip flexors, and they are just fine, but I find it's really the calf that is tight, and they have the difficulty getting through the hip, and one can affect the other. Likewise, a tight hip flexor can affect the opposite shoulder. We talked about in flexibility highways, the anterior X factor that goes from the opposite hip across the obliques through the pec to the opposite shoulder. And we can see this in the respect that if you're tight in the hip flexor, which could also be affected by the calf, but if you're tight in the hip flexor, you are not going to have as much extension and rotation to the opposite side. In other words, the opposite shoulder won't extend as far, and you won't rotate to the opposite side as far. So we need to make sure that we look at that relationship and not only work our clients, but mobilize our clients and then strengthen the ability to control from the opposite hip to the opposite shoulder. One of the most common limitations that I see, particularly amongst runners, cyclists, swimmers, multi-sport athletes, people who have had ankle problems, people who have had knee, hip problems, or knee or hip surgery, or the sedentary, or the elderly, is the lack of loading in the frontal plane, what we commonly have been referring to now as the lateral flexibility highway. If you cannot load in the frontal plane and get good hip adduction, you are going to limit the ability to rotate to the other side. You're going to limit the ability to have internal hip rotation. In fact, if you just adduct the hip and just do a toe step and see how much rotation you get into that hip, and then slightly abduct that hip and rotate, you're going to see that the pelvis won't rotate as effectively into internal rotation of that hip. So we need to make sure that we have adequate motion in the frontal plane to allow rotation to the opposite side, to allow loading of the opposite side, to allow extension of the opposite side. So we see loading of this side is going to affect unloading of this side. If this is tight, this will stay loaded for a bit longer. So again, a common limitation that I see is lack of frontal plane motion through the hips, which will affect sagittal plane motion, which will affect rotation. The study of the adductors over the course of the years, I have greatly appreciated how powerful the adductor complex is and how much pelvic dysfunction and SI joint dysfunction they can create. We must make sure that we have good rotation and good lengthening, eccentric loading of the adductors. Now notice I said rotation. The adductors do not adduct the hip in gait and in upright functional movement. If we go side to side, if we do a side lunge as an example, this adductor is going to lengthen eccentrically to decelerate hip abduction. But we don't walk like this. We walk in a pattern, obviously with a contralateral reach, but this hip that is extended, the adductor of the extended hip is helping decelerate hip extension and external rotation. The adductor of the lead leg of the flexed hip helps decelerate hip flexion and internal rotation in gait and in motion. If they get tight, if the adductors get tight, it's going to limit the ability to get through the hips in the transverse plane. It's going to limit the ability to load the hips in the frontal plane, but it's also going to have a huge impact on your inability to get into good sagittal plane movement. So the adductors really work in three planes of motion. Extremely powerful, but make sure that we get the motion, that we get mobilizing through sagittal, frontal, and transverse planes, so we get them loaded and lengthened in all three planes of motion. Likewise, we talked earlier, what is the pelvis doing in kyphosis? You see somebody that is kyphotic, the pelvis is going to go into a posterior pelvic tilt. You're going to see that the femurs will go into a slight externally rotated position. You're going to see the lumbar spine flex, thoracic spine flex, shoulders protract, cervical spine flex, head goes forward and down. So our kyphotic posture is affecting the entire chain. It is not just affecting the thoracic spine. We need to make sure that we address the thoracic spine, but also the pelvis, because one affects the other. If you're kyphotic in the thoracic spine, it's going to impact the pelvis into a posterior tilt. If you're tight in the hip flexors, if you're tight in the abdominals, and it's creating a posterior pelvic tilt, it's having an impact on the lumbar and thoracic spine, as well as the cervical spine. And also, the last common limitation that I see is a tight shoulder girdle. Anytime that shoulder girdle, I'm talking about not only the glenohumeral joint, I'm not talking just about the humerus, I'm not talking about just the clavicle and its motion at the sternoclavicular joint, but I'm also talking about the scapula and its ability to glide on the ribs. That entire shoulder girdle, when it becomes tight, will impact gait from the top down. In other words, when we see motion such as this, or we see motion that's this, and we see that this shoulder is able to get into extension, you're going to see retraction of the scapula. you're going to see the rotation to the opposite side or the side of the extended arm. But if you don't have that motion, the scapula is not going to move as well. The scapula is not going to retract as well. You're going to see there's going to be limited rotation to that side of the extended arm. And we start to see tightness develop through the entire chain, especially through the transverse plane. So those common limitations, we need to address them to enhance proper function, to enhance proper performance, and allow the entire system from the foot all the way up to the thoracic spine to operate and to have optimal performance.
To summarize the common limitations, when I think about the three most common injuries suffered in society, one is low back pain, two is knee pain, the third is shoulder and cervical spine pain. Often these are results from immobility in one or more of the four big movement rocks. If you look at these injured regions, each one is between a big movement rock. For example, the knee is stuck between the foot and ankle complex and the hip. The low back is in the midst of the hip and thoracic spine. And the shoulder is dependent upon good mobility of the scapula, good motion at the sternoclavicular joint, which is dependent upon the action of the thoracic cage, which is dependent upon the action of the hips, the foot, and ankle complex. Make sure that these four big regions, the great toe, ankle complex, hip complex, thoracic spine complex, can move in all three planes of motion, and you will see a significant reduction in the risk of injuries.
Many of the programs, many of the curriculums, many of the textbooks that talk about fitness program, talks about program design, really doesn't take into account what goes on at the foot. If we think about it, the foot is the conduit between the ground, and the foot's going to react to ground reaction forces as well as gravity pushing down on it. The foot has 33 joints, 26 bones, 24 muscles, and those muscles want to be eccentrically loaded first. They will stabilize and then concentrically unload. We have to understand what goes on at the foot, because I'm a firm believer that if we have foot dysfunction, we're going to see dysfunction throughout the entire kinetic chain. I've seen many cases, people with knee pain, hip pain, low back pain, have a foot issue, a foot problem. In the fitness industry, I believe we just need to understand four major components. If there's any pathology, we must refer that out. But the four major components is understanding what is going to happen at the foot to create an environment for the entire system to become successful. Those components are, think of it this way. As the foot hits the ground, gravity is going to take the foot and drive it into the ground. But to make the system successful, to turn on the glutes and to make the hips function properly, to make the low back function properly, what the foot must do is go through calcaneal eversion. As we go through calcaneal eversion, the foot again hits the ground and the foot starts to flatten out as we dorsiflex into mid-stance. Calcaneus is going to evert and the tibia is going to internally rotate. You look at it from the side, you're going to see the foot hit the ground. Dorsiflexion occurs as the hip goes over the foot. Look at it in this respect. Foot hits the ground, hip moves over the foot. I'm dorsiflex at the foot and ankle complex. So we have calcaneal eversion, dorsiflexion. That is going to cause tibial internal rotation. Think of it this way. You have the calcaneus, and you have the talus that sits on top of the calcaneus. Think of the talus as a rider on a bicycle. As that bicycle starts to lean one way, the bottom of the tire goes outward. Think of that as pronation, because pronation is the bottom of the calcaneus is driving laterally. But the bone itself is driving medially, but the bottom, which is the tire, is driving laterally. We look at it in this respect. So as that happens, the talus is going to dive in, because you as a bike rider, as your bike starts to tilt, you're probably going to look to see where you're going to go. Now on top of the talus, think of a long helmet. That long helmet is called the tibia. As you as the talus turn one way, that helmet is going to turn with you, and the tibia is going to internally rotate. So we have three components going on so far. We have calcaneal eversion, dorsiflexion, tibial internal rotation. Now here's the last concept, and that's forefoot abduction. If you recall, when we look at movement away from the spine, we look at the distal bone in relation to the proximal bone. In other words, we see that the long bones, the tarsals, and we see the phalanges are going to go abduction or lateral to the calcaneus. But there is no real motion, such as the arm right now is going into abduction. There is no real movement, but relative movement when we go into forefoot abduction when the foot hits the ground. And the reason I say that is as the foot hits the ground and the calcaneus dives in, remember the calcaneus is moving probably further and faster than the forefoot, creating forefoot abduction. So in reality, we have relative forefoot abduction as the calcaneus moves medially. So as a review, the four big rocks that we need to make sure the foot is going through is calcaneal eversion, dorsiflexion, tibial internal rotation, and forefoot abduction. If any one of those components gets limited in motion, you will see that the system is going to become limited in motion, and that's when we often develop compensations. Once we get those motions, and the tibia internally rotates, and the knee is going to abduct, and the knee is going to go through internal rotation, and the femur will internally rotate, and the femur will abduct, and then we flex, the gluteals are maximally loaded in three planes of motion. That occurs all because of the success that has been created by the foot.
The system that I have been using in recent months is a system called QuadraStep. QuadraStep was developed by a podiatrist and physical therapist in the United States. QuadraStep has converted 24 different foot types into similarities that will represent 6 different foot structures. In other words, the podiatrist has identified commonalities amongst the 24 different foot types over the years, and he's been able to classify or categorize 6 different foot structures and has prefabricated an orthotic system. The first we're going to discuss is the severe pes cavus, the common characteristics that we typically see. The pes cavus foot structure is characterized by a high arch, large inverted rear foot, forefoot valgus, and a large tibial fibular external rotation. This foot structure does not allow optimal pronation, resulting in poor shock absorption. Recalling the 4 big rocks of foot function, to optimally load the lower extremity and gluteal complex and to enhance shock attenuation, the calcaneus everts, ankle will dorsiflex, tibia will internally rotate, and the forefoot will abduct. In this video clip, notice the heel whip at the moment of heel off. This is a common compensation to attempt calcaneal eversion and stabilize the first ray during heel off. This foot structure reduces ankle dorsiflexion, thereby inhibiting the 4 big rocks of the foot. Typically, the individual with this foot type has a narrow gait and propels from the first metatarsal head rather than more evenly forced distribution across the metatarsal heads. Watch for callus formation on the 5th and especially the first metatarsal heads. The common symptoms that we typically see with a severe pes cavus is that this foot type does not have adequate motion, and these people often suffer from lateral ankle instability, tightness of the perineals, frequently getting perineal tendinitis. They have heel pain and often low back pain. The next category is the mild pes planus. Mild pes planus most often presents as a low medium arch, mildly inverted rear foot, forefoot valgus, moderately externally rotated tibular fibular alignment. As the calcaneus is mildly inverted, this uses up some of the available motion to evert the rear foot, thereby affecting the remaining 4 big rocks of the foot movement, meaning compensated tibial internal rotation, reduced ankle dorsiflexion, and inadequate forefoot abduction, resulting in poor shock absorption. Notice as the heel lifts, there is a momentary medial heel whip, but immediately after, the calcaneus attempts to invert. This helps to propel the foot, but remains pronated during the mid-stance phase. The propulsive phase of gait is primarily from the first and second metatarsal heads, and there is a toe-in gait. Due to the prolonged medial to lateral forces upon the forefoot, there is an increased risk of neuromas, sesamoiditis, hypermobility of the first ray, and SI joint pain. The neutral foot structure typically has a medium arch, moderately inverted rear foot, normal forefoot alignment, and a neutral tib-fib alignment. The subtalar joint usually has a normal range of motion, approximately 6 degrees, but in many occasions can be tight and restrict subtalar joint pronation. If this is the case, the ankle will have limited dorsiflexion and shock absorption. This gait is often characterized by a toe-out foot strike and propulsion from the first metatarsal head. If this foot type becomes problematic, common symptoms present with hip or low back pain, iliotibial pain, and a pinch callus at the medial first metatarsal head. Moderate pes planus has a low arch, which is very common with those possessing a moderate pes planus foot structure. The rear foot alignment is vertical, as well as the forefoot, which is in a neutral position. Mild internal rotation is seen at the tibular fibular alignment, and a positive toe sign often results. The gait pattern exhibits prolonged pronation through midstance and propulsion in the second and third metatarsals. In many cases, the mid-tarsals are unstable, and the individual often lacks a forceful gait. This foot type frequently results in plantar fasciitis, hallux limitus, patellofemoral pain, neuromas, and bunions. Callus formation is typically seen at the second, third, and fifth metatarsals. Abductovarus forefoot. One of the more common foot structures, the abductovarus forefoot displays a medium to low arch, mildly everted rear foot, a mild tibular fibular internal rotation, forefoot varus, and a positive toe sign. The toe sign meaning that the majority of the toes can be seen on the lateral aspect of the foot. During the gait cycle, notice how the rear foot excessively pronates as the heel raises. A heel whip often ensues. These actions are a result of the foot compensating to achieve stability at the first ray. When assessing the foot in a non-weight-bearing position, the arch appears normal, yet in mid-stance of gait, the arch collapses. This is due to the compensations articulated above. However, notice the increased supination of the foot as the heel rises, and the forefoot abducts during propulsion. The fifth metatarsal is often the pivot point during the gait cycle of this foot type. Common injuries found in the abductovarus foot are shin splints, plantar fasciitis, and medial knee pain. The most common flat foot is the severe pes planovalgus. This foot structure is described as a flat arch, everted rear foot with a large tibular fibular internal rotation and forefoot varus. Due to the lack of calcaneal eversion and accompanying reactions, this causes poor shock absorption. With a positive toe sign and the compensation that ensues during the propulsive phase of gait, lateral column instability is often seen within this population. Callus formation is often seen at the second and third metatarsal heads. This is caused by the prolonged forces on this region throughout the gait cycle. Common symptoms often occur in this structure are posterior tibialis pain, plantar fasciitis, patellofemoral pain, and hallux limitus. The single leg balance, lower extremity anterior reach to 0 degrees, measures and assesses motion in the sagittal plane. This assessment views actions of the lower extremity while loading in the sagittal plane. Important motions to analyze in the quality of ankle dorsiflexion, calcaneal inversion, tibial internal rotation, and forefoot abduction. Common compensations that often occur are too much flexion at the hip, which does affect the foot reaction, such as toe clawing, inversion, and forefoot adduction, which can be very common. One of the movement components is limited or compensated, and all other actions will be compensated as well. When we have immobility in the foot or the ankle complex, one of the strategies we try to provide is to mobilize the ankle and to do pivotal toe touches, which will be explained in program design. In the frontal plane, single leg balance, lower extremity, lateral reach to 90 degrees. This test views the same action as the previous, only with the lower extremity moving in the frontal plane. The non-weight-bearing leg will impact the weight-bearing leg or the affected leg by causing a frontal plane reaction. The expected outcome should be increased calcaneal eversion, ankle dorsiflexion, tibial internal rotation, and forefoot abduction. These actions are necessary to flex the hip, adduct the hip, and internally rotate the hip of the weight-bearing leg. Again, if there's immobilities, some of the strategies that we will apply would be ankle mobilization techniques and pivotal toe touches. In the transverse plane, single leg balance, lower extremity rotational reach to thresholds. This is a key assessment technique I find extremely valuable as it demonstrates the client's ability to move in the transverse plane. Limitation into internal rotation will impact the client's frontal plane loading as well. I am watching the midline of the body, not how far the non-weight bearing leg moves. In other words, look at the midline, look at the seam of their shorts, or if they're wearing a belt, and see how the pelvis is moving, not where the non-weight bearing leg ends up. This motion should come through the pelvis. Notice as this assessment is being done, the hips and shoulders go together as one unit. I try to advise the client not to separate hips and shoulders. When we look at some of the strategies, ankle mobilization is critical. Toe touches in the transverse plane is critical. What we need to try and capture is more motion in the transverse plane of the hip, but we have to understand why it is not occurring. Transverse plane thoracolumbo hip rotation. This assessment technique is used to analyze the segmental rotation of the thoracic spine. Consider there is more rotation in the proximal segments with lesser range toward the lumbar spine. Compare symmetry of motion when turning one way versus the opposite. View if the client can rotate without capturing the motion through the hips. It is critical that there be adequate motion in the thoracic spine to protect the lumbar spine, as the thoracic spine is one of the most mobile regions of the body. If it becomes limited in motion, the lumbar spine often compensates to allow the necessary movement in the transverse plane. Frontal plane thoracolumbo hip lateral rotation. This assessment technique is used to analyze the segmental rotation of the thoracic spine in the frontal plane. Consider there is about the same amount of motion in the frontal plane in T1 through T10 segments, with slightly greater range over and toward the lumbar spine. Compare symmetry of motion when turning one way or moving one way versus the opposite. View if the client can laterally flex without capturing the movement through the hips. Lateral flexion is critical through the gait cycle. Some of the actions that we watch for. We want to make sure that the feet and ankles stay relatively neutral. Is the motion coming from the hips versus the lumbar versus the thoracic spine? Is the thoracic segmental motion moving adequately in both directions? And how is the scapula moving? Some of the chain reactions is the hip and thoracic mobility is necessary to protect the lumbar spine. Some strategies to gain motion in the thoracic spine is triplane lunges with triplane arm reaches, type 1 and type 2 spinal motions, and triangulated shoulder press. Thoracic spine motion actually takes place on all three planes of motion, not just one that occurs simultaneously. We call this either coupling in the more traditional sense or tripling, meaning three planes of motion at each segment during thoracic spine movement. After determining transverse plane motion, we have to assess type 1 motion, which is measuring the lateral flexion in one direction while rotating in the opposite direction. Then look at the type 2 thoracic motion, which occurs when lateral flexion and rotation occurs to the same side. These motions are important to help protect the lumbar spine. Most movements in normal daily activities are more of the type 1 nature. This slide is a reprise from Stuart McGill's book, Low Back Disorders. Notice the small range of motion in the upper 5 segments of the thoracic spine, with increasing motions in the lower segments toward the spine in the sagittal plane. Considering the lumbar spine is highly conducive to movement in the sagittal plane, it makes sense that there is the most motion in the thoracic spine at T11-12 and T12-L1 levels. In the frontal plane, the thoracic spine has relatively consistent motion in the segments T1 through 9, about 6 degrees at each level. T10 and 11, slightly greater range. T11-12 has 9 degrees, and T12-L1 is approximately 8 degrees. This is consistent with the motion in the frontal plane in the lumbar spine. The segments T1 through 9 has about 80 degrees of motion, with considerably less at T10 through 12, has a range of motion of 10 degrees, totaling about 90 degrees in the thoracic spine in the transverse plane. Notice that the motion reduces closer to the lumbar spine, which is not conducive to transverse plane motion, only about 13 degrees cumulatively. Based upon these findings, it is critical that the range of motion be maintained in the thoracic spine to reduce the risk of injury in the lumbar spine. Again, from Dr. McGill's book, lumbar spine has good mobility in the sagittal and frontal planes, especially in levels L1 through 4, with lesser degrees of motion as it approaches the lumbosacral junction. Notice the very limited motion in the transverse plane, but increases from 2 degrees in L1 through L4 to about 5 degrees in L5. This motion slightly increases because the hips have good range of motion in all 3 planes of motion. When assessing the cervical spine, we can think of the cervical spine almost like a bobblehead doll. In other words, most of the movement is in the cervical spine is a reaction from what occurs below the cervical spine. There are 4 assessment techniques that I use. One is the sagittal plane, cervical spine, flexion, and extension. We can move the head into flexion and extension, which will cause a top-down reaction in the cervical spine. However, what we will see is that we want to drive it from the bottom up, and there will be a reaction to see what is going on below the cervical spine and how it is affecting the cervical spine. Then we will do a frontal plane, cervical spine, abduction, adduction, transverse plane, and then combinations. As the lunge is performed at knee height reach, notice the extension that takes place, the relative extension that takes place in the cervical spine. There is not real motion in the cervical spine, but the relation of the cervical spine to the thoracic spine becomes relative extension. In many cases, when I have seen people with cervical spine pain into extension, they do not have the motion in the thoracic spine, and the resulting injury has occurred from excessive use in the cervical spine. Flexion being the same way. As we do a posterior lunge with an overhead reach, there's relative flexion of the cervical spine rather than taking real movement of the cervical spine. So I will assess in both manners. Flex the cervical spine, but then I want to see what the relative movement of the thoracic spine in relation to the cervical spine that occurs. Lateral flexion. We can have our cervical spine laterally flex one way or the other by bringing our head into lateral flex movement. That will laterally flex the cervical spine. Or what we can do is see how the thoracic spine and the shoulder girdle affect the relative motion of lateral flexion. We can drive our left ear towards the left shoulder or bring the left shoulder to the ear. This will tell us what is going on below the site of the limitation. Remember, in the spine, we measure the movement of the proximal segment in relation to the distal segment. We can turn our head one way or the other to assess transverse plane motion of the cervical spine, but when we move from the bottom up, we have relative rotation of the cervical spine. In this case, there is now rotation to the left, even though the thoracic spine is moving to the right. It creates proximal versus distal, created that relative rotation to that respective side. Our next section will discuss program strategies and training techniques based upon human motion and biomechanics. Ideas and considerations regarding personal training and sports performance will be demonstrated. Please take the time and practice some of the assessment techniques that we have just demonstrated. Become comfortable with them and then start using them with your clients. Remember, we want to compare your clients' progress to themselves, not to others of their same age and gender demographics.